Because more babies die during the first week of life than any other time during the whole first year, that first physical examination is a very special and important examination. We should remember that each baby has a history, and there's a tendency to forget this. Each baby has a history that lasts 9 months, and each baby has a history in the delivery room. So that in doing the newborn physical exam, we should be aware not only of the immediate physical findings, but the obstetrical history, the APGAR score in the delivery room, and the history since birth. It's important to examine those parts of the baby first that will least disturb the baby. That would include palpating the fontanelles, listening to the heart, palpating the abdomen, and feeling the femoral pulses. Once that's accomplished, then you can do the remainder of the physical exam with the baby crying. There are two fontanelles basically. The anterior fontanelle is diamond-shaped and should be under mild tension with pulsation. The posterior fontanelle is usually closed and is triangular-shaped in the immediate newborn period. The point of maximal impulse should be felt. This usually lies just to the left of the midline. Then the heart should be auscultated. The normal heart rate usually varies between 120 and 180 beats per minute. Should be sure that there is a split-second sound. If the point of maximal impulse is detected to the right of the midline, then one should suspect that there's some process going on in the chest that is pushing the mediastinum to the right. The femoral pulses are not always easy to palpate and may require repeated examination, but basically, if you take hold of the knees and extend the index finger, you can palpate the femoral pulse without much difficulty. Now, Catherine has just been fed, and palpating her abdomen may be a little difficult. I don't want her to spit up. The spleen may be palpated on the left, in the left upper quadrant. It's not unusual to feel the spleen tip. And with a bimanual examination, you can feel the left kidney, usually without much difficulty. The right kidney is less likely to be felt because of the overlying liver. It's not unusual to feel the liver edge. If you palpate gently, starting from the right lower quadrant and working up, feel the liver edge 2 or 3 centimeters below the right costal margin. Once these preliminary aspects of the exam are performed, then you can start either from the feet and work up or from the head and work down. The important issue is that you develop a systematic approach so that you don't overlook anything. Let's start from the top. Back to the fontanelle. The fontanelle, anterior fontanelle, is diamond-shaped. Good pulsation. There may be overlapping of the sutures, and that's not abnormal with a prolonged labor due to molding. We should inspect the scalp. It's important to run your fingers through the scalp to detect any congenital defect of the scalp, especially in the midline. It's important to observe the ears. Are they low set? An imaginary line drawn between the eye and the occiput. The tip of the ear should lie above that line. The ears are normally formed, and although it's often of little value, the ear canal should be visualized. I say of little value because there's frequently debris in the ear canal, and it's not rewarding to try to clear that debris from the ear canal. Frequently there are capillary hemangiomas over the eyes or over the nape of the neck, and these are referred to as the stork bite nevus. Mothers frequently ask questions about the capillary hemangioma, and you can reassure her that the capillary hemangioma will disappear within 6 months to a year. Observe the eyes and the movement of the eyes. Are the extraocular movements intact? Frequently the newborn will follow a light, in this case, I think the lights are so bright all around us that it doesn't make that much difference to Catherine. But the eyes should be observed for cataracts, and you can do this by reflecting an indirect light and then once you've assured yourself there are no cataracts, and I'm not going to do this in any detail, but you should assure yourself that the pupils react equally, and you should see the red reflex, which is by direct visualization of the retina, the light bouncing off the retina. To do a more sophisticated fundoscopic exam requires cyclopedic drops and a lot of patience, and we won't do that here. Now, how do you tell if the baby has a patent airway through the nose? Babies are obligate nose breathers, so if you simply close the mouth, the baby should not develop any significant distress. And Catherine, there you go. She's closing her mouth herself, and she's breathing quietly through her nose. And if you want to test to make sure both sides are unilaterally open, just close one and then the other, to assure yourself that the choana are patent. Frequently, just by touching the mandible, the baby will open the mouth. Catherine does that nicely, and you can see, even without a light in this case, her soft and hard palate, her tongue. There are no teeth, which sometimes are present, and her oral pharynx is normal. An area that's frequently overlooked in examining the newborn is the neck. Babies have short necks. We should palpate every square inch of the neck as well as the entire surface area of the baby, looking for midline masses, which might be a thyroid goiter or a cystic hygroma. A mass lateral in the neck could represent a cystic hygroma or a lymphangioma. Working on down, we always palpate the clavicles in their entire length, feeling for crepitus, which would indicate a fractured clavicle. At this point, I would stop and observe Catherine for a moment. We can learn a lot just from observing the baby. In this case, Catherine moves all four extremities equally well. If you notice the baby not using one extremity as frequently as the other, that there's a flaccid arm, this would suggest that she might have a fractured clavicle or a brachial plexus injury. Her color is pink. Her hands and feet are pink. Babies in the immediate newborn period may have what we call acrocyanosis, that is blue hands and feet, but if their lips are pink, this is a normal finding. Notice how she breathes. The respiratory rate in the newborn is about 40 breaths per minute. She's not in any respiratory distress, just mild seesaw respiration, which is normal. We observe the position of comfort. In the term newborn, she is flexed. Her upper extremities and her lower extremities tend to be flexed on her trunk. The more premature the infant, the less that is true. We observe the nipples. We look for extra nipples, and these can occur anywhere in the so-called milk line, which is a line essentially in the anterior axillary line. Frequently, the newborn has a prominent xiphoid in this area, and mothers will ask you, what is that lump sticking up from my baby's chest? And you can tell them with assurance that that's just the tip of the baby's sternum or breastbone, and that's a normal finding. Now, Catherine's cord is gone, but in the normal newborn with the cord intact, there are 3 umbilical vessels, and you should count those, 2 arteries and 1 vein. If you only count 1 artery, this might be suggestive of a congenital anomaly, most frequently that of the urinary tract. Now, the genitalia in the normal term female show that the vulva are quite large. The labia cover over the clitoris, and although we can't see it on camera, the clitoris and the hymeneal tag are quite obvious. This is perfectly normal. To check the hips, if we abduct the hips like this, and then gently rotate the femur in the hip joint, and try to feel for a click. In addition, we examine the hips by noting the creases on the thighs. Are they symmetrical? If they're asymmetrical, this might suggest a dislocated hip. And dislocated hips do occur 3 to 4 times more frequently in female newborns than males. Catherine's creases are symmetrical, and there is no hip click. Moving on down, we notice that her feet are in a neutral position. Frequently, newborns, either their tibia or their forefoot will turn in. And if we can reduce that to a neutral position just with minimal pressure of the finger, that is probably positional from intrauterine position, since the baby occupied this position in utero, and that any slight torsion will resolve itself before the baby starts walking. It's important to count the fingers and toes. If you don't, mothers will. Extra digits frequently are familial, and they may cause quite a bit of concern for the anxious family. Now let's take a look at your back. We should pay special attention to the midline. Feel over the vertebra for midline defects. And if there are clumps of hair or areas of pigmentation or dimples or masses, these are suspicious that there might be an underlying vertebral defect. Discoloration over the buttocks, so-called Mongolian spots, are more typical in black babies and are of no significance. Now finally, the neurologic evaluation consists of several reflexes. Baby will turn as you rub the inner side of the mouth toward the pressure, the so-called rooting reflex. The Morrow reflex is done by slightly elevating the trunk off the bed and then letting go, The baby responds with a startle, extension of the upper extremities, and frequently will then adduct the upper extremities. This helps us get a further idea of the intactness of the upper extremities. The grasp reflex further defines the the intactness of the upper extremities. The lower extremities can be checked with the stepping reflex, and believe it or not, Catherine can walk pretty well. Once completed, it's important if the mother is at the bedside or the exam is done in private, to report your findings to the mother. Go over in detail any abnormalities that you found. If she's seen her baby and examined her baby before you have, she'll have lots of questions, and you should be prepared to sit down, loosen your tie, and spend a few minutes at this, the most important time, the most important physical examination a baby will ever have. Michelle, I've examined Catherine, and I wanted to review a few things with you. You've probably already done this, but she has all of her fingers and toes. Her heart sounds fine. Her lungs are clear. I've felt her abdomen. Everything seems to be fine. She's got a little discharge from her vagina, which is normal for a baby of this age, and that's no problem. Basically, what I'm trying to tell you is that Catherine is a perfect baby.
Thank you.
As we get to the end of this tape, I would like to make a few comments about some things that I think are important with regard to the newborn physical exam. One, the newborn is not a small adult. We need to keep that in mind for several reasons. One, the newborn, when the first physical exam is done, is usually in a state of transition. The baby is making the adjustment from the fetal circulation to the adult circulation. Two, as I've said earlier on the tape, more babies die in the first week of life than the remainder of the whole first year. So the importance of this exam cannot be underestimated as we try to find abnormality. The third point is that every family of a newborn baby is anxious, even if the baby is doing well. Pregnancy is characterized by ambivalence on the part of the mother and the father, the hope for the well, perfect child, the dreaded thought that their baby may be deformed, abnormal in some way, or might die. So this examination and this time of sitting down and reviewing the findings with the family is an important time. A few other points about attitudes. If we accept that this is the most important physical exam that you or I ever had, and then it's important to adapt an attitude that is somewhat different than physicians may have had in the past. And that is that in the past the attitude has tended to be that every newborn baby is well until proven otherwise. And I would like to suggest that we take a slightly different attitude and keep in the back of our mind that every baby is potentially ill until proven otherwise. Thus, the burden is on us, the caretakers, to prove each and every newborn baby well, instead of assuming that every baby is well until a problem crops up. The final point I'd like to make is that we try to develop a systematic approach to the newborn physical exam. In this way, we observe and touch and listen to every square inch of every baby. We don't miss anything, and we essentially do each physical exam the same way we did the last one. If we're systematic in our approach, then there'll be less opportunity for error.